are online all around the world. This is the third annual event that the ILC UK has run alongside the World Health Assembly. And I'm sure you'll appreciate the token that we've brought to you today by bringing with us UK weather to intervene and add light to our proceedings. My name is Lawrence Churchill. I'm recently been appointed as the chairman of the ILC UK. My previous experience is in the insurance sector, in the private insurance sector. And I guess as I'm in Switzerland, I can say that I used to run Zurich International and Zurich UK as part of my portfolio in yesteryear. But lastly, I've been more of a pensions expert and have done a lot of work for the UK government in setting up new different types of pension systems. My experience also includes, though importantly, 2 health insurers. And I think that's my sole qualification for appearing before you today. I've got some familiarity with the health space, but of course, nothing at all to rival the expertise that's here in the room. But this year, we'll focus on what it takes to build a society fit for the future. Our Healthy Aging and Prevention Index has found that since the COVID pandemic, we are actually living shorter, unhealthier, and more unequal lives in a world that is less environmentally sustainable. In a world that's aging, these trends cannot continue. We know that there's a clear consensus that investing in healthy aging, including preventative health, is critical for building more resilient societies that are not only healthier, but wealthier too. And yet, ensuring adequate investment has been an ongoing challenge. And with the possibility of disinvestment in healthy aging, halfway through the decade of healthy aging, we must act quickly. As countries across the world grapple with the impact of demographic change and population aging, we must focus on the long-term solutions and commitment to ensuring better futures for everyone across the globe. Now, today, we're pleased to be here again to share new findings from our index, and most importantly, identify ways forward to build a society that's fit for the future. And I urge you to share today's conversation and to post comments on LinkedIn or on the ILC X handle at ILC UK using the hashtag Prevention Index. Now, today, we will be joined by a fantastic group of panelists, including Peter Baker, the Director of Global Action on Men's Health, David Elvira Martinez, the Corporate Public Policy Head of Sanofi, Marco Lamarca, the Cabinet of Dubravka Suica, Commissioner for the Mediterranean European Commission, and Sohel Salkat, Senior Advisor, Primary Healthcare, and lead the Health Systems Resilience and Essential Public Health Functions for the World Health Organization in Geneva. And finally, Whitney Tom, Senior Business Director of Development at the Sabin Vaccine Institute. After the panel discussion, there will be time for a Q&A from anyone in the audience. But before we hear from our panelists, I'd like to invite Aran Himawan, Senior Health Policy and Research Manager at ILC, to present new findings from the index. Aran leads ILC's Global Health Programme and the Healthy Aging and Prevention Index. Aran, over to you.
Right. Good afternoon, everyone. I am really delighted to be back here in Geneva to present new findings from our Healthy Aging and Prevention Index. For those of you who are joining us for the first time, our index is an online interactive tool that ranks 153 countries on 6 healthy aging metrics. We look at lifespan, health span, work span, income, environmental performance, and happiness to understand how well governments, how well countries have adapted to longevity. 2 years ago, we launched the first wave of our index, and this was a very good starting point for us to understand what are the current state of affairs when it comes to healthy aging. Last year, we launched the second wave of our index, and this was also a big milestone because it enabled us for the first time to track progress, which way our countries are headed. This year, I'm pleased to say that we have spent a lot of time really trying to understand and unpack what is driving good progress on the index. Why is it that some countries perform better? And we've looked at a range of issues, starting from vital preventative health interventions like life course immunization, to understanding the healthcare system that supports it, and even wider to understanding the role of environment, the role that environment plays in our health. And this is incredibly important for us to understand this so that we can present to governments a compelling case for why they need to be investing in healthy aging and ensuring that their money is actually put to the most effective interventions that will have a long-term impact. Before I go ahead and present our new findings, I would like to do a very quick recap as to what we've learned so far with our index. What you see in front of you are the top 50 countries on our index, looking at the latest wave, wave 2, looking at 2022 data. And what we find is, generally speaking, the top 50 countries on our index have seen little movement, on average 2 places up or down. When we compare this to the bottom of our index, it's a lot more volatile. We see a lot more movement, on average 4 places up or down. But that's not to say that we have seen some movement on the index at the top of our index. For instance, between the first wave and the second wave, we see that Iceland has overtaken Switzerland, I'm afraid, as the top spot. When we look at the top 20 countries, a third of them are EU. And the vast majority of countries are high-income countries, but it's not just high-income countries that feature in our top 50. You will see a few of the countries, low and middle-income countries, that also feature in the top 50 on our index. So what's happened over the 2019-2022 period? And Lawrence very briefly gave you a recap of what's happened, but here are some of the specific findings. So we are on average living 8 months less. We spend 7 fewer months in good health, and we are less environmentally sustainable than we were previously. We've also seen a widening of health inequalities by 1 year. So when we look at the top 10 and bottom 10 countries on our index, in 2022, there was a 27-year difference for lifespan and a 24-year difference for health span. Happiness levels have remained relatively unchanged, I'm pleased to announce. And we work the same number of years, and on average, we are richer. And I say on average because that's a big caveat. Income inequalities between the top 25 countries on our index and the bottom 25 countries on our index have widened. And in fact, this is the worst type of broadening of inequalities, widening of inequalities that we're seeing, because actually those at the top have seen an improvement in GDP per capita, and those at the bottom have dropped in GDP per capita over this time period. So this is quite a worrying trend we don't want to see continue. So we're left essentially with the question, given that we're living in a world that's unhealthier, less wealthy, less environmentally sustainable, where do we go from here? What can governments do to get back on track and see improvements? So first of all, our research has demonstrated that there is a clear case for investing in preventative health. Countries that invest more of their health budgets on prevention as opposed to cure perform better on our index. You'll see 2 outliers here on our graph, Canada and the US, where Canada spends a higher proportion of its health budget on prevention. And we actually see this in terms of the health outcomes and index outcomes as well. Canada ranks 13th on our index, the US ranks 31st on our index. And the population in Canada experiences and benefits from an additional 6 years lived in good health compared to the US. But it's not just investing in prevention. We also have found that there are certain interventions, like investing in adult flu vaccine, that can have a positive impact. Looking at OECD and EU countries, we found that there's quite a huge difference between the top 5 countries and the bottom 5 countries that invest in terms of adult flu coverage rates. So if we look at the top 5 countries on our graph, they on average have an 82% uptake rate. They have an average lifespan of 81 years and an average ranking of 25 on our index. Compare that to the bottom 5, we see on average that they have an uptake rate of only 10%, a lifespan of 76, and an average ranking of 51 on our index. I'm very pleased to also say that today we're launching our new publication on HIV and longer lives. Thanks to antiretroviral therapy, people are living longer with HIV. And what we can see generally is that high-income countries, countries at the top of our index, have a smaller prevalence burden, and they also have a higher health span. But these countries are also facing a challenge where people are aging with HIV. Older adults already make up 50% of the population of people living with HIV among high-income countries, and they also represent 20% of new cases. And what we've also seen is that they're also at greater risk of comorbidities, and as a result, they're less likely to be diagnosed. They're also more likely to have poorer health outcomes. We've also seen that progress has stalled. So if you look at the graph, those ranked between 31 and 60 and those ranked between 61 and 90 have actually seen an increase in prevalence rates. Older adults face a lot of challenges when accessing healthcare. Ageism is widespread, but those with HIV also face additional barriers outside of healthcare. For instance, a third of adults with HIV are unemployed. So where does that leave us? Our publication presents a number of different policy recommendations. However, the one that I want to leave you with is ensuring that there's a new approach to tackling HIV in an age of longevity. High-income countries need to have strong HIV action plans, and aging needs to be at the forefront of those discussions. Now, we often talk about high-income countries and demographic change and aging, but low and middle-income countries are also undergoing this shift. And in fact, they're actually undergoing aging at a faster pace than their high-income counterparts. One way that we can address or improve health outcomes across the life course is by investing in universal health coverage and actually ensure that people are aging well and aging healthily. And our index quite promisingly shows that low and middle income countries have seen huge improvements in universal health coverage. Over the last couple of decades, there's been a 60% increase, and that has led to a 25% reduction in inequalities between the top and bottom of our index. However, since 2015, progress has stalled. The proportion of households spending over 10% of their income on healthcare has increased for all economic groups except for low-income countries. And LMICs do still lag behind high-income countries by 22 points on UHC. We also find that countries at the top of our index who invest more in UHC, have higher UHC coverage, also benefit from 16 years spent in 16 more years or additional years spent in good health. So where does that leave us with UHC? Well, clearly one of the things that we call for very strongly is reinvestment and proper investment and strengthening into primary healthcare. This is the bedrock of universal health coverage. It ensures that people can have access to the vital preventative health interventions, can mean the difference between them living or dying, and more importantly also when they do get older, living well. And also ensuring that we can invest in and strengthen national healthcare schemes to ensure that we reduce the burden, the financial strain that's placed on so many people across the world because they're unable to pay, because they have to pay for healthcare. Now, we've mostly talked about physical health, and I want to briefly talk about our mental health as well, because of course this is part of the discussion. And this time last year, we were in the same room speaking to experts about what it is we can do to reduce the mental health burden. What can we do to address and tackle this issue, particularly for those with chronic mental health conditions? We already know that there's a huge number of years lived with disability due to mental health conditions, and this has a very real impact on people's ability to participate in society. And our index, one of the metrics on our index, it measures happiness. Now, this is, of course, a very superficial top level of understanding mental health, but it gives us a good starting point for understanding what's going on at a global level. And what we generally find is countries that are happier are also higher on our index. Mental health, of course, places a huge burden on our economies too. 4.2% of GDP is lost annually due to poor mental health across OECD countries. So later this year, we have an opportunity at the high-level meeting to really engage policymakers and collectively agree that we need to invest more strongly into mental health infrastructure, that we need to recognize its toll on society, and that we need action. And moving out a little bit further, looking at climate change, social determinants of health is incredibly important when thinking about global health, when thinking about healthy aging. And climate is shaping our health in many ways. What we did with our index is we wanted to really understand the impact that it has on life expectancy. And we looked at particulate matter 2.5, which are particles of a diameter of 2.5 micrometers or less. They are the most harmful types of air pollution, and they are linked to heart disease, COPD, lung cancer, pneumonia. Children and adults are most at risk. Our analysis finds that the impact of air pollution results in a reduction of life expectancy by 1.8 years. Now, of course, this is an average. So those countries that are in the top 50 of our index only see about a reduction of half a year. But if you go further down onto our index, those ranked 100 or above see on average almost 2.5 years lost life expectancy due to air pollution. Now, the WHO recommends an annual average of 2.5 of PM 2.5 should not exceed 10 micrograms per cubic meter. However, as you can see in this graph, only the top 10 countries on our index are fully compliant. On average, 2/3 of countries on our index are non-compliant. Now, what we wanted to understand is, are we seeing this when it comes to health? Are we seeing air quality have an impact on health outcomes? Not quite yet. We can't see the full cost and toll that it's taking, but we are likely to see this in the future. What we can see at the moment is high-income countries are particularly have a high burden of respiratory disease mortality, and this is due to a number of factors. One is they're aging; they've already aged, so they're more likely to experience this burden. They're also experiencing a legacy of smoking. So as this starts to dissipate, we're going to see a bit of a swap effect, a shift, where more of the cause will come from environmental factors. And what we can actually see already here is such a very high burden among countries ranked 21 to 30. These are all EU countries. They include countries like Italy as well. So when it comes to the future, we have an opportunity now to act on the impact of air pollution to ensure that this burden doesn't continue to rise and that we start to see a flattening out across the globe. So what needs to happen next? I've spoken quite a bit about what governments can do to improve health outcomes of their citizens. And if you remember at the beginning of my presentation, I talked a little bit about investing in prevention, but we wanted to really put this to the test. We wanted to understand what would happen to life expectancy if we were to model it against healthcare spending. Does it track? Is spending healthcare actually translating to better health outcomes? So, and I promise you, this is the most complicated slide I have on this deck, and I've decided to end with it. But essentially what we found is that life expectancy is almost entirely a product of per capita health spending. And the more you spend, the better. But what we also find is that the ratio of prevention spend adds vital years to life expectancy. In fact, it can add up to 3 years. And given current spending towards prevention is already quite low among OECD countries, it's about 3% of health budgets. You can just imagine the even further impact that investing in prevention can have in terms of adding years to life. So as we go further down the index, you will see that there's other forms of spending that's not accounted for in healthcare spending. And this includes foreign aid, includes the role of NGOs, and this adds up to a year of life expectancy for those countries. And this just underscores the vital role and continued role that they play in global health. As we go even further down the index towards the end, we'll see that our modeling has gone a little bit off track here. And this is because the vast majority of countries here are undergoing political crisis. So our expected life expectancy isn't quite matching with what we're currently seeing. But I want to end with a very final point, which is we have a very strong call for both high-income countries and low and middle-income countries. We want high-income countries to increase their investment in prevention to 7.8% of their health budgets, matching Germany, who currently spends the most across the world and the most among high-income countries. For LMIC, the priority is to increase their spending per capita across both healthcare and prevention to really ensure that they can speed up and start meeting and reducing the inequalities between what we're currently seeing between high income and low and middle income countries. So I'll leave it there. I'm really looking forward to the discussion with our panelists. Thank you very much.
I'd like to invite the panel to join me on the stage here for our panel discussion. And while we're all gathering, can I just say a massive thank you, Aaron, for a wonderful presentation, full of discoveries that you've made from researching the index. It's a gift that continues to keep on giving, I must say. So, brilliant insights. Thank you very much indeed. We're now coming to the part of our afternoon where we're privileged to have such a established panel of world-renowned speakers, if I may say so. What we've done for this session is to set them really three questions about where we are at the moment, some of the characteristics of where we are at the moment, and what does the future hold. And the first question is about the barriers that we're currently seeing to improving outcomes and the priorities as people see them now for governments around the world. I'll read out the full question that we set them just to make sure that we're all on a level playing field of information. And the first question reads, in a post-COVID-19 world, and with the Sustainable Development Goal targets fast approaching, what are the biggest barriers to improving health outcomes across the life course? And what must be the key priorities for governments across the globe to tackle them? So that's the first question. And I'm going to look to see which of the panel is most enthusiastic to take the lead in answering this question. Marco, I saw a smile there. I think it must be you.
Happy to kick off. Thank you very much for this introduction and for inviting me. As I'm just as a brief self-introduction, I'm working in the cabinet of the Commissioner for the Mediterranean, who is also responsible for demography. And since our work for demography that started already in the past mandate between 2019 and 2024, while now it is going on, we have already been working a lot on the dimensions of let's say on the policy challenges related to the demographic trends. In particular, we have been working on the aging of the population, which by itself we consider as a start to be good news. It's the result of progress. It's the result of well-being. It's the result of a lot of things that we have been wishing for during the whole history of the humankind. Now, what is really needed in order to prepare for this longevity society is really an adaptation of the institutions and of the structures, because right now our life is indeed organized around certain parameters that are changing, notably the duration. Our first assumption has always been that aging starts at birth. So we have been starting with a youth guarantee and a child guarantee to ensure that people grow up and live all their life in the best possible conditions. And this is where prevention starts. Half jokingly, I always say that if you start exercising when your knees hurt, it's too late. You should have started much earlier. You should have started to avoid basically that to happen, not to, as a reaction. And this is really the key, at least from our points of view, to have a long to have a long life and enjoyable, notably, because of course the prolongation of the lifespan is not good news enough if it's not accompanied but also by prolongation of the health span. Now, it's true that Aaron has been saying that in the recent years there has been a slight decline, and I'm not contesting that. But the reality we observe in the society is that things are changing because that decline is only slight, and the macro trend is going to the other side. We have been insisting a lot on even what we called longevity literacy, which is preparing the people to know and to plan differently their life, knowing that it has a different duration. Of course, this regards the financial planning, this regards health, this regards a lot of dimensions of our life, our career planning, etc. Even our training need to take into account this longer duration of life. I would stop here for now so that we can be as interactive as possible. But
oh, good. That's great, Marco. You've already prompted several questions in me to come back at you. But let's, in the absence of any other metronome, switch to the other side of our table. And David, could I ask you to address the same question: the biggest barriers and the key priorities?
First, thank you for the invitation, and I will take some of the ideas of Marco here. I will start that maybe there is one real need, that is a kind of change of mindset, or even political mindset. And the mindset is to real believe that prevention is what we need in the public policies for health, right? And here we had the opportunity to see two metrics, right? We're living less in a kind of a fewer quality of life. This is a wake-up call for all of us. Don't we have the tools to avoid that? We have the tools. We have seen also during the presentation that, for example, for the adult flu vaccination, as an example, that is kind of not correlate, but there is a relationship with the way we perform in terms of the healthcare outcomes. It allows to provide value in different dimensions, not only health, of course. But look, today we are discussing in this town about a resolution on NCDs, right? And also we can see the connection of prevention with the way we manage chronic diseases, right? Because we know, for example, for adult vaccination, that we will avoid cardiovascular events. In a dimension, just for sharing, if you don't have fresh in your brain the figures, I'm pretty sure not, with an impact on avoiding heart attacks that is almost half, right, of the probability. That means similar to the impact of smoking cessation. So there is a relation very clear in the way we improve the management of non-communicable diseases and chronic diseases by prevention. But not only this, let me just to anticipate, and we will have time to add how prevention is also connected to other dimensions of society. And let me just highlight two. One is the economic impact. A healthier population, thanks to prevention, is more productive. We have to bear in mind that, because when we are saying where is the problem in the policy mindset, maybe it's because we are not explaining other value dimensions of prevention, economic productivity. But there is another one. It's about resilience of our healthcare system. We will be discussing for years and years about how unsustainable is our performance of healthcare services provision. Lack of professionals, pressure on our healthcare system, resilience crisis. Prevention is also the way to make our healthcare systems more resilient. And that's important, that's relevant for the healthcare policymakers. So this is another dimension that maybe we have to explain in terms of where is the problem on the mindset, why we are not changing to prevention. And let me just highlight the last one, that is about society, right? We all deserve and we have the right to be in all of our best of our selves in any age, right? If we want to thrive at every age, what we deserve as human beings, we have to be clear that prevention can provide that you have healthier, more productive lives. And this is important for the economy, this is important for the healthcare system, but this is important for us as a human beings. I take it, I keep it here, and then we can have additional further discussions on that.
Thank you very much, David. And Peter, can I bring you in now at this point for your perspective?
Yes, thank you very much. And thank you for inviting me. I work for an international NGO called Global Action on Men's Health. You may not have heard of us, but we're based in the United Kingdom, and our work is about putting men on international health policy agendas where they're largely absent at the moment. I think it's important that I say at the outset that we're an organisation that wants to see gender generally on international health agendas. We're not making a special case for men. We think that both men and women should be, their needs should be fully met. It's not a choice, not a binary choice here between one sex and another, one gender and another. We think that men's health and women's health is inextricably linked. If we improve the health of one, we improve the health of the other. We rise or fall together. Having said that, I'm here on behalf of a men's health organisation, so I'm going to talk about men. And if we think about longevity, there is a particular problem with men. Clearly, we can't improve longevity without addressing the poor state of men's health in every country in the world. There is no country where men live longer than women. In fact, in every country, it's the reverse. If you look at the global data, men live 5 years fewer than women. They have shorter healthy life expectancy as well as life expectancy. Men have a 40% higher mortality rate from cancer. Generally, if you look at all the cancers together, they're more likely to die from cardiovascular disease, from diabetes, from tuberculosis, from HIV and AIDS. Virtually any metric that you look at, men do worse. Suicide will be an example from the mental health field. And this is largely overlooked. At Global Action, we've looked at 4 key areas of international health policy. We've looked at cancer, mental health, sexual and reproductive health, and use of primary care services. And men are largely absent from global health policy. We also know that they're largely absent from national health policy as well. So what we've got is this weird situation where men's outcomes are not good, the opposite, they're bad, but then that is a problem there's a blind spot there. It's not being addressed. Now, we need to think about this differently. We need to have a different mindset. We need to think about men and women's health in a new way. And if I was to say something about men's health, what needs to happen? I think we need, yes, as David said, a greater focus on prevention, tobacco control, alcohol, diet, you name it, improving health literacy. We're making a lot of noise at the moment about HPV vaccination, and we think that HPV vaccination should be extended to all young people, maybe some older people as well. But certainly we want to see gender neutral or universal vaccination introduced in every country in the world. At the moment, only about half of those countries with HPV vaccination programs vaccinate boys. And that's a major problem. And these are particularly concentrated in the lower and middle income countries. Because if you only vaccinate girls, you don't protect the whole population. Even though women are more likely to get an HPV-related cancer than men, there are still 180,000, at least 180,000 cancer cases in men each year caused by HPV. But by vaccinating the boys, you actually protect the women they're having sex with, because a vaccinated boy can't infect an unvaccinated woman. So we'll actually accelerate the decline in cervical cancers and other cancers in women if we vaccinate the boys. So we need to do better on prevention. The other area I'd highlight is early diagnosis. And we're not doing very well there either with men. We could do better with both men and women, of course, but men, things are particularly poor. So, for example, we're not doing enough to detect hypertension early enough. We're not detecting bowel cancer early enough. And we're certainly not detecting prostate cancer early enough. We're seeing a predicted doubling over the next 20 years in the number of cases of prostate cancer. And unless we introduce screening programs, which we now know how to do, the introduction of MRI screening in prostate cancer has made an enormous difference. We now know how to run screening programs. And there's a big trial going on in Europe at the moment, the PRAISE-U study, which is exploring how to introduce the feasibility of introducing prostate cancer screening. I'm confident that when that reports next year, it will actually give us a clear signal about how we need to introduce prostate cancer screening programs, because prostate cancer in its early stages is asymptomatic in most cases. So unless we can detect it early, we're never going to get on top of it. And prostate cancer alone could overwhelm, it'd be like the next diabetes. It will overwhelm health systems if we don't get to grips with it. So my call would be, from a men's health perspective, we need to do more on prevention. We need to do better on early diagnosis.
Thank you very much, Peter. We can see the themes beginning to emerge already, I think. And Sohail, if I could turn to you. I mean, David mentioned the issue of systems resilience, which of course is one of your special subjects. So perhaps within your remarks, you may pick up that and develop that theme as well.
Lawrence, thanks a lot. So colleagues, let's go back to some of the fundamentals here. So the global population size now around 8.2 billion. And then if you look at the service coverage from universal health coverage point of view, I think more than 50% do not have access to basic package of health services. And then if you do further breakdown, around 2 billion are in a financial hardship. This is a reality. I mean, it's not a reality only countries in income setting, is also prevalent in countries in high income groups. At the same time, the social deprivation, inequality, these are all not just a phenomenon of poor countries. Then if you think about what is happening in sub-Saharan Africa as well as Middle East, I think that also constitutes another quarter of the global population. So this is the hard global realities that we are in. But then if you stratify the priorities, I think some priorities we as a health community we can do, but in some priorities we have limited influence technically, but we might have some political influence. So what we as a health communities can do, I think first one is, we have been talking a lot about primary health care. I think that is basically the first line of defense. I think, Lawrence, you mentioned about resilience. But if you think of the primary health care, because I also trained up in United Kingdom, I think the perception of the primary health care is a one-to-one medical care. So the primary health care needed to embrace public health more effectively. If we can position public health in primary care, that means your work on building resilience is almost 50% done. Given that the first point of contact, for example, an infectious event and the health system, if you have public health orientations in the health workforce and facilities as primary care level, that means you are protecting secondary and tertiary care. And if you look at our experience during COVID in Europe, unfortunately, the type of health system that we developed, we have been feeling very proud of, unfortunately did not work. Even countries with high universal health coverage index, countries with high global health security index, unfortunately, there was no correlation. So it was a complete lack of resilience in countries in all income group, although some parts of the world can claim that we did better. But again, we need to look at the demography and the some of the other functionality aspect, like the reporting system in those part of the world. Then the other point, we need to be very, very careful. I think during COVID-19, every country either printed additional money or borrowed money or transfer money to the health sector. So if you think as a health community, before COVID, we had a one baseline, one settlement for health sector. So during COVID, we had an artificially high settlement. So post-COVID, we cannot expect that we'll have a same baseline that we had, unfortunately or fortunately, during COVID-19. So we need to come up with a more smart, affordable baseline. So in that context, there are a few things we can do. I mean, I believe you all came across Lusaka agenda. I think it's talking about more about integrations, more focusing on building systems capacities, one plan, one budget, one monitoring. Otherwise, some of the particle programs that we have, given they are dependent on ODA and given fiscal constraint we are experiencing, they can be unaffordable. And I think we have a body of work on resilience. There is so much reference about resilience. I think it also needs intentional input, the way we construct and build our health systems. And there are many aspects of public health underpinning. I would kindly suggest us to look at also some of those technical packages that we as a WHO develop. Back to Lawrence.
Thank you, Sohail. Some very sobering remarks, if I may say so, there, particularly on funding and how we've performed and what we've still to do. But can I finally turn to you, Whitney, and ask you for your thoughts on the topic of barriers? And I mean, I know you've worked in some of the toughest parts of the world, so perhaps if you could tell us some stories emanating from your background as well, that might be very useful.
Sure. My name is Whitney Tom. I'm the Senior Director of Business Development at the Sabin Vaccine Institute. My career started actually similar, I think, to David in the humanitarian response sector, primarily focused in Afghanistan and Pakistan, and then moving into the Middle East, focused on Syria and Yemen. So I think when it comes to accessible preventative health mechanisms, I think I started out in the hardest places. Now I think this audience, I think many people are from middle or high income countries, Europe, and I work for an organization that's about vaccine equity. And when we talk about longevity, I want to share 4 things that I think we really need to consider whether or not you're a low income country in a fragile area or a high income country. Number 1 is, I think, as Sohail rightly said, making sure the healthcare system is really in one solid piece and you have an understanding from birth, as you were saying, until death, being able to know how someone is receiving healthcare services. So you might say this is primary healthcare. You want to make sure that childhood routine immunizations are there. A sobering fact, but something that is tracked well, is measles outbreaks is something we've probably all seen in the headline. Raise your hand if you've seen measles in a headline this year. And you know why? Because in 2022, only 36 countries had measles outbreak. In 2023, that number rose to 57 countries in the world. 10 of them were here in Europe. Just think about that, 10 countries. I come from the United States. We have also been experiencing a lot of measles outbreaks this year. So not investing in primary healthcare, not investing in these basic tools, as Sohail was just saying, that we have available to make sure we have at least over 95% coverage, which is difficult if you think about, because other vaccines only need maybe 80%. We have to get the basics done right. Because imagine yourself, I was with the Minister of Health in Somalia this morning, and he said, how many emergencies do I have to focus on at the same time? Think about it. Measles, drought, oh, then flooding, oh, now cholera, right? So let's get the basics right. And then you move to life course. Peter and I have something very in common. We're partners formally, part of the Global HPV Consortium. We have the tools to prevent cervical cancer, anal, penile cancer with this HPV vaccine. And yet only 1 in 5 girls, less for boys, get this vaccine. This is silly. What are we doing? We have the tools available to us. So let's get these basics right. Second, I would say, is consistent political will. How many decisions are made from the Ministry of Finance on health that are related to when the next election is? So if you're with the government, if you know of someone in the government, ask them, how might you make decisions that are investing in the next 5 to 10 years, not just between now and the next time you're up for re-election? Third, Aaron did a really great job really showing us how air pollution has impacted health. What we're hearing from governments for vaccines is, please give us more information, early warning systems, where we combine climate predictive models with health predictive models using our data collection on the ground to tell them ahead of time when outbreaks are going to happen. So whether that's arboviruses, so viruses from mosquitoes that are obviously growing because of climate change, cholera due to water and sanitation, or measles, please, like they're asking for us, let's combine forces between private sector, technology, and governments so that we use artificial intelligence to make it easier to plan ahead in this preventative approach. And then lastly, I'll say is something that's uncomfortable, but that I think I enjoy talking about, maybe because I have 4 older brothers and I like kind of stirring things up. There's a lack of incentives for private sector partnerships in health. So what Sohail might be wanting to do, what my non-governmental organization might want to do, what Sanofi might want to do, sometimes maybe they're not exactly aligned. But how do you find the middle ground to have shared goals that really can meet business goals with government goals around how we actually drive longevity in each country?
Thank you, Whitney. Yeah. Thanks very much. Tour de force, clearly massively committed, I think, to change. But of course, the nature of change is very difficult. I said before I had a pensions background, and within the pensions world, there is a constant repetitive theme of, will political parties please stand aside? We know what we need to do. Let us get on with it institutionally. But of course, the government's there to get re-elected, and their cycle is a very different cycle to the one that you're thinking of. And what's the prospects in health for pushing harder? We have the WHO and great organizations focused on these issues. Do you see any prospect of having government step back?
Is this for me?
Yeah.
Step back or step in, I think maybe. I think, we focus globally, but a lot in middle income countries we see as opportunities in adult vaccination, respiratory diseases in particular. We have current respiratory vaccines, but we also have some in the pipeline. I'm really hoping for the tuberculosis one, but we have influenza, we have pneumococcal, we have RSV. So I think I would love governments to step in and ask themselves, even amidst perhaps trying to address these acute disasters around measles outbreaks, how might I set my healthcare system up to prepare for the increased respiratory diseases that we know are coming, that this atlas shows us? David, you were talking about this in the EC. Like, I think this is something that I would love a government to step in and put the next political win aside and actually say, no, this is the right thing for my country, aside from what I'm going to do next in my own political career.
Thank you. Well, in the interest of time for this part of this, I'm now going to move on to our second question, but I promise you I may well come back to some of the themes that are already lurking, I think, in the undergrowth. But our second question was all about inequalities and what's driving that trend and how can we reduce inequalities. And I'll read out the full question that we've given our panelists to speak to. It goes, there are huge inequalities, not only within countries, but between the global north and south, and they seem to be worsening after a period of continued improvement. What are the new challenges countries are facing that are driving this trend? And what can governments realistically do over the next 10 to 15 years to help reduce them? And again, I'll ask who would like to. David, thank you.
Okay, maybe I start this time. Look, first, I would react to this question about the scope of inequality, right? It's not only north and south, it's west and east, and it's inside the countries, right? So the scope is changing, especially if we are not having the countries back and in, as Winnie was saying, right? First, the scope. Second is about the sources of inequalities. I think we are not very conscious about new sources of inequality that will drive us to put the focus on certain therapeutic areas. Let's talk about climate, health, and pollution, for example, where you see that the impact of pollution is more in LMIC than in high-income countries, right? And at the same time, it's not the same to have COPD, for example, related to the respiratory challenges. When you are, for example, a Black female in US, than if you are not in terms of exacerbations, just because you are more impacted because the inequality is impacting your health. So scope should be in our radar. The sources of new inequalities can help us also to focus on what are the challenges, the health challenges where we have to be working, especially in prevention, and respiratory is a very good example. And the third is about, okay, if we are focused on these priorities, why we are not investing on that again, right? And I give you just one question for you. Just imagine that you can invest $1, and then you have 14 in return. Would you say that this is a good investment? Not bad, right? But just imagine that the same euro or dollar is invested and you have 19 in return the same year. That's perfect investment, right? This is adult flu immunization. But we are not investing on that. Government, what is the limitation? Maybe because we are not explaining or prioritizing with our finance, ministers, where to put the money. Because, when you have a return of investment of 119, if you are not investing in that, you are shooting your feet as a finance minister, right? It's not, so I think we have to start also to think about that, because this is the solution to fight again these new inequalities with different scope, with different sources of inequality. I leave it here.
Thank you, David. I mean, that's sounding the nearest thing I've heard so far to a magic bullet. So maybe we'll return to that as well. But Peter, can I draw you in on for any additional remarks that you have on this topic?
Well, I've already talked about some of the inequalities in the sex and gender field. I won't reiterate them, but I'd just make a point about gender norms. I think there are kind of two broad explanations about why men's health is poor. One is to do with the way policies are designed. I mentioned those before. The other is about the way services are delivered, which are not particularly male-friendly. Often they're quite hard for men, particularly men of working age, to use. And they're about simple things like appointment systems for primary care, opening hours, the way those services, that men don't often feel comfortable for using them because they seem to be services primarily designed with women and children in mind. So there's that kind of side of it, but the other side are gender norms, the way in which boys and men are supposed to behave. This is sometimes called the man box, the kind of constraints that limit men's lives, the way that they can express themselves, difficulties men have asking for help, and so on. And those gender norms are, although I sort of reluctant on the one hand to stereotype and to talk in huge generalizations. On the other hand, there's a lot of truth in this. And across cultures, all cultures, these gender norms around masculinity are pretty similar. Whichever kind of culture, society you look at, we see the same basic things going on as far as boys and men are concerned, and the way they're brought up to behave, the way they express themselves, and so on. And of course, their attitudes to health. And on the one hand, we have to develop policies and services that take that into account and work with the grain of how men are. But on the other hand, we have to think about, well, how can we support men to behave in a different way, to think in a different way, if they want to. I mean, we're not about sort of, not engaged in vast social engineering projects here to kind of rewire men's brains, but we have to kind of think about how we can support men to think and behave differently, to remove a lot of the stigma that is attached to using services, particularly services that men deem embarrassing, particularly around sexual and reproductive health, sexual dysfunctions, and so on. Yeah, I think I've lost my train of thought. I'll stop there and I'll come back in a minute.
Okay,
That's the kind of basic point I wanted to make.
Thank you very, very much. Very important point. Marco, would you like to take up the challenge and add your thoughts?
Yeah, actually, I have very limited points of view, considering that the European Commission has very limited competencies when it comes to health and health system, health organizations, but the organization of health systems. But let's say inequalities don't only inequalities in health don't only reflect into the health system, but they're also part of, for instance, recalling what also David was saying earlier, in the labor market. Let's say we are very concerned with this kind of inequalities. For instance, I'm talking about the divide between the blue and white collars. Of course, they have the life they lead takes to very different health outcomes, notably when years accumulate. And this is something that I think did not receive so far enough attention. I'm personally thinking of it quite often when it comes to the adequacy of social protection and pensions. We often speak about pension systems that are not fit for this longevity era, and that should be changed. But still, I think that we should differentiate. So this is just to give an example of another dimension of inequality. We should differentiate between let's make an example just to simplify things. A mason who by the beginning of his or her 60s, right, his 60s, has some physical issues with a white collar that instead has a completely different life and completely different prospects when the 60s begun. So these are things that I think are not taken enough into consideration that while they should.
Thank you. Thank you.
Lawrence, can I just come back to the point I forgot to make?
Absolutely.
I'll be very brief, thank you. What I wanted to go on to say was that we used to think that men were changing. There was this kind of, going back to the 1990s, there was this idea of the new man, kind of slightly feminized version of what men used to be like. And there was a kind of optimism that younger men in particular were adopting new ways of being more open, finding it more comfortable to talk about health, mental health in particular. Now I'm not so sure. I'm really worried about the way in which young men in particular are being influenced by what's called the manosphere, by bad actors in this field. The name Andrew Tate, I'm sure is familiar to you. It's the name that's always mentioned because he kind of personifies a lot of the ways in which younger men are being perhaps led down a blind alley or in the wrong direction to think about themselves. And I think as we're seeing a trend towards more authoritarian more authoritarian populist politics in many liberal democracies now, I think I'm worried that we're going to see a reinforcement of traditional masculinity. Now that's problematic in all sorts of ways. It's problematic for all of us, but just from a health point of view, I think if we see men taking more risks with their health and a reinforcement of those barriers that are inhibiting men about discussing health, seeking help, and so on, we're going to have more problems in this area rather than fewer.
Thank you, Peter. Point very well made. Now, Sohail, can I turn to you for your thoughts?
Thank you, Lawrence. I think one aspect I again wanted to remind us that we are in a very hard reality now, I think from a global to country context, in an unprecedented hard reality. Yes, we often talking about poly crisis, but then if you think about the current global directions in terms of the flow of funding to the health sector. So there is a significant reduction in ODA, which is a common phenomenon now, unfortunately. And then there is this protectionistic economic policy. So there can be two types of impact. One is the direct one, ODA reduction. It will have impact on some of the programs that we have in low and middle income country setting. But if this type of global policy directions financially continues, I think we can have further contraction even within the country. So even if country remain committed to spend 8% of GDP on health, or in Africa context, 15% of GDP, but the size of the envelope, the size of the total envelope will shrink. So it's not just the impact of ODA, it's also the shrinkage of the envelope that we expect in every country. So how can we, in this complex situation, I think it's not that straightforward. I think if you look at the role of the Ministry of Health, again, I'm not mentioning any country's name here. Ministry of Health is not in the top quartile of the ministerial setup. Sometimes at the mid-level, sometimes even many countries that do not have a full Minister of Health. So I think we need to have a different types of diplomacy. And in that diplomacy, we need to convince the government and policymaker that this is a premium that they need to accept. If you buy Mercedes, if you buy BMW, if you buy some of the other expensive car, we all buy insurance, isn't it? So during COVID-19, we have seen that without that insurance, how can all other government business functions can disrupt? So can we have a real settlement for health sector that let's consider the investment in health as a premium to pay? So for example, if you talk about the primary healthcare, WHO's recommendation is 1%. So can we convince in every country that let's put 1% additional GDP for primary healthcare? But then we as a health community, we also need to apply their business and economic logic because we are not very good on that. I think because the policymakers, they want to see the transactional aspect. If I give you $1 billion, what is the outcome that I can get? So we need to apply the business logic that if you invest in this type of non-transactional mode, there are going to be economic return. So if you have another pandemic, we could say that now in the COVID pandemic, you have spent $1 trillion, but we need to convince them that in the next future pandemic, you do not need to spend $1 trillion. And also number of excess mortality that you have can be further averted. And then the most important one, I think I congratulate this discussion in a way that how can we judge a society as a good society? I think the society that look after the people who are elderly, who are living in a marginalized, who are economically deprived. If our society do not look after them, as we had seen during COVID-19, many people in ethnic background, many people in old home died fast. So in the future, I think these are some of the ammunition, some of the argument that we need to make to the politician that let's consider your investment in health as a premium. You're having Mercedes, you're having some of the expensive, why can't you also do your investment in health sector with a little premium? Thank you, Lawrence.
Thank you, Sohail. And I apologize, Whitney, for the second time in succession I've come to you last.
Best for last.
Well, as well as that, where I was grown up, the lady always had the last word on every topic, but I won't come to you last for the third question. Your thoughts?
I think my colleagues, I mean, they covered a lot. I think maybe I'll react a bit more and double down. I think for the HPV vaccination case, many of you may know that in 2020, the World Health Organization put out a cervical cancer elimination plan. Cervical cancer focused on women, of course, but if there was no action taken between this time right now and the end of 2030, the global economy will lose $28 billion. And that's because imagine putting yourself in a situation where someone between the age, a female between the age of 25 and 45 is diagnosed with cervical cancer. Most of the time, because of lack of screening on both female and men's side, we're catching it in the last stage where there's very little you can do, and maybe your country doesn't even have options. So HPV vaccination and I think cancer screening are absolutely something that really does underscore inequities if you aren't going to a healthcare facility regularly. In regards to the healthcare system, Sohail, I appreciated that macro level view of what does it mean to invest in health? What is this, to me, a social justice issue of what is a human right? We say this so all the time, right? Health is a human right. But something that stood out to me this morning was the UN's Children's Fund had a youth delegate from Ukraine come, and she said, health is the foundation of our society. Please stop building on a broken foundation. And that investment in our healthcare systems from birth all the way to death, let us invest there. Right now, there are very few middle high income countries who have adult vaccination registries. So we have no idea. We have ranges of, oh, maybe between 20 and 60% of people are getting the pneumococcal vaccine or the influenza vaccine, or have you ever had shingles or heard of someone who had shingles and like sometimes the long, complicated things? We have a vaccine for that. What are we doing? So if you've ever tried to buy it, you can probably answer one of the top reasons why we're not doing that. And lastly, I'll say, I think in regards to this investment, I want to underscore a particularly unique challenge of middle and high income countries who don't have Gavi eligible vaccine pricing. So Gavi, the Global Vaccine Alliance, negotiates pricing for about 54 countries right now, right? In the next 10 years, about 14 countries will not become eligible for Gavi pricing, which means we have more countries than not even now who really need to understand how to afford these vaccines that are coming out right now for adult immunizations. And so the way that a government has to negotiate either pricing through the Pan American Health Organization, through UNICEF, through partnerships directly with manufacturers, or maybe it's that access pricing through one different pooled procurement regional block. It is so confusing. So my encouragement, and I think this inequity, is let's make it easier for middle and high income countries to use the tools that we have and then to invest in the healthcare systems so that adults can take advantage of current vaccinations and preventative measures, but also the ones that are coming out. And I can talk a lot about my excitement for future preventative and therapeutic vaccines, but in order to have the realization of the innovation and research and development, we must have ways to actually reach people.
Thank you, Whitney. Now I'm going to move on in the interest of time to our third question, third and final question for the panel. And I'll ask the panel, I think, to answer quite succinctly, because it's a succinct question. It goes, many people across the globe are aging in poor health, a trend set to continue. Yet much of this poor health is preventable. If you had a magic policy wand, what would be the one thing you'd like to see happening at the country or global level to keep populations healthier? And I'm going to come from David and sweep across the table, so Whitney is not last again. David, over to you.
Okay, thank you. So I think it's not a matter of magic, it's something that is reachable. And maybe it's more a call to action. That is, who can do, please do. And we can start, for example, with governments in countries. Just one figure. You know, prevention is average OECD countries less than 6% max. And 10% of this is for immunization. So 0.5% of the healthcare expenditure. Just put it as part of the GDP. But even with that, we have some problems sometimes to for high income countries to pay for innovation. And just following the thread, right? The thought thread is if who can pay is not paying for this innovation will never arrive to the rest of the world, right? And we are thinking about 0.5% of the healthcare expenditure in average OECD countries, right? So it's more a call to action. If you can do it, do it. I'm a representative of the private sector. Just one, what about you? And what about us? About us is having the correct portfolio, following the correct incentive, and also providing, for example, solutions. And I can bring the example of my company, but it's shared with other similar companies, to have units that are non-profit, non-loss, even non-philanthropic, because not always philanthropy is sustainable, but non-benefit, non-loss business, it is. That's why, for example, we have this, in our company, we have this global health unit on this proposal for the 40 countries, poorest countries, with the 35 essential medicines to ensure access. So if we can do, we should do. That would be my one.
Thank you, David. And Sohail, your one magic wand.
Thank you, Lawrence. Just maybe two magic one. One, I think the solution we all know. I mean, it's not a magic. I think we need to have the primary healthcare as an approach for health systems strengthening. I think there is no other options, and in that configurations, we need to define the role of primary healthcare for preventative, promotive, and other life course specific services. So that should need to be universal. I think this is what WHO is keep advocating for. Second one, I think we often talk about health for all policies. I think given the global constraint that we are seeing, whether this is the time that we can step up our game within every country to advocate for this type of policy. What does it mean? What does it really mean at country level, so that the planning, urban planning, social care, the flood risk protection, climate change, etc., all can be a little bit more respectful about their actions, the actions of the commercial sector in relation to public health. I think that is something definitely we need to find commitment. Second one, I think Whitney mentioned, I think often private sector is not considered in mainstreaming in terms of their commitment to the health sector. Think about the Chinese investment in Africa and many countries. There are trillions. So what about government to allocate 0.0000 something to consider health also as an infrastructural development, as an infrastructural requirement, as a premium? Thank you, David Lawrence.
Thank you, so. And on to you, Whitney.
I had very similar ones, so I might choose a different one. I'll plus one to one policy, one being minimum % of allocation to health sector and immunizations, and I'll second Sohail's around defining primary health care across the life course. I think I will add surveillance nationally, that's community-based, to have qualitative context data paired with clinical lab surveillance, so that you have a better picture of each country. And then a global policy one would be where we have more integrated surveillance systems rather than these verticalized disease areas that don't allow you to really see the full picture in a region or a country, to enable policymakers to make some hard decisions over what your focus might be and where you invest. And my bonus would be more incentives for private sector partnerships.
Right. Okay, thank you. Marco.
Yes, since I don't think I'm wiser than my colleagues who already gave very valuable answers, I will just try to be more original, and I will break the unspoken rule that we shouldn't talk about anecdotal evidence. So I will tell you about something personal. One of my best friends is a dentist, And a few years ago, when my eldest son was like 8 or 9, I thought he had an issue with his teeth. So I asked my friend to have a look. We were both on holiday in our own village. And so he didn't have his own tools and everything. So he went to his uncle, who is also a dentist, and he's known for being a funny guy. So basically, when my friend introduced me to his uncle, he told me, "Don't you know Marco? We were friends since middle school, etc." And he said, "No, I never met him." I looked at me and said, "Good for you." Now, he was giving it for granted that not going to the dentist is a good thing for everyone. Now, I don't want this to be funny. I want people to go to the doctor and to do prevention.
Okay, three things, but very quick things. Tobacco control, effective tobacco control across all countries in the world. Gender neutral HPV vaccination worldwide by 2030, and gender, men's and women's health in all health policies. All health policies must be gendered fully, and also that we should have specific men's health policies. There are a few countries that have them at the moment. Ireland is perhaps the best example. It's had a men's health policy since 2008, and it's had a huge impact. We've seen men's life expectancy. I'm not saying there's a direct correlation, but there's a correlation, but not necessarily causation. But since Ireland had a men's health policy, men's life expectancy in Ireland has gone from being pretty low by European standards to being the highest in Europe.
A few minutes left to take questions from the floor. If anyone has a hand there, there will be a mic. Oh, lots of hands. There will be a microphone. I'm not sure we've got that much time, but if you can get a microphone round to the first person. I think it was the lady in the middle who had her hand up first. If you could say your name as well and your affiliation, if you have one. And if you want to direct a question to a particular individual, please say so.
Hi, everyone. Thank you very much, panel, for your really interesting discussions. My name's Ima Mir. I'm the CEO of the Asian Resource Centre in Croydon, UK. I just wanted to draw on some points from Sahel, where you spoke about post-COVID baselines and financial pressures. And Arun, you spoke a little bit about the increasing life expectancy by a year by NGO activities. I run an NGO, and I wanted to know how can the index be used to support the case to policymakers for NGO investment to improve life expectancy, because prevention is at the heart of what we do. And I know you've made a good case for private sector investment, but what can we do to increase investment within NGOs?
Who would like to?
I don't mind. Anyone can answer that one.
Anyone like to go further? Yeah.
I haven't actually looked at what data is out there in terms of measuring the impact that NGOs have. But if you can point me to the right direction, I'd be very happy to take a look at it and to look and see if there's any relationships that we're seeing between investment and the role of NGOs in various countries, both in high-income countries and low and middle-income countries. I should also mention, and I didn't get a chance to earlier, but we're currently working on developing a UK index. And so the role of community services, I think, will be particularly important here. And I think this could be something we could definitely bring forward to better understanding what's happening at a local level. What are the roles of community organizations like yourself in the spaces serving the people that need access to vital interventions the most. So very happy to continue that conversation and explore and see what we can do with that.
Okay, Lily, the gentleman over there next. Yeah.
Thank you. I'm Dr. Richard Heron. I'm co-chair of the International Occupational Medicine Society Collaboration. That's occupational professionals in 52 countries who touch about 1 billion lives. I want to build on something Peter sort of touched on and challenge David, who's trying to convince finance officers in a 5-year cycle. How does the panel persuade voters who are most harmed by cuts to prevention and yet consistently support leaders who carry out those cuts? to vote? How do we persuade them to vote in ways that are in their own enlightened self-interest? Because that will change the behaviour of ministers if they get voted out.
Oh, wonderful question. Peter, do you want to go first on that one?
Competition the previous slide.
Okay,
Yes, I
yeah,
will.
David?
I can jump in.
All right, okay.
Okay, first reaction then. As my former head of politician, right? I've been a payer, so I've been trying to convince my finance minister that it was good to invest in investment, right? And I think what were the main limitations to convince them? One is that we are not well equipped with evidence sometimes. Sometimes we are not convincing, you know, because our evidence is not in the same political cycle. That's the point. I can convince someone that my impact will be in 10 years when the elections are into average. So in some European country, right? So I need to build evidence about return of investment in a shorter time, period of time first. Secondly, I would say that sometimes we are not discussing about tools that are so clear for finance ministers, but so far from the day-to-day from health ministers, like, for example, budgetary laws. Look, we know prevention is an investment, right? It's not an expenditure, right? This is our kind of claim. Investing in prevention, not wasting. It's not expenditure, it's an investment. We can provide evidence about the return of investment of 114, 119. So where is the problem? It's not considered in the definition of budget that is an investment. It's an expenditure. It could be a drug, it can be services, but never define an investment. We start in Europe to have some exceptions, right? Because, you know, the Stability Pact in the European Union starts to say that investment in prevention will have some kind of exceptions to reach the Stability Pact in the European Union countries. That's a starting point, because this is the language of the financial ministers, I would say.
Okay, thank you, Dan. Whitney will take this one. Okay, all right, you got some. Whitney, you go first.
My first response is I worked at Facebook, now called Meta, for 3 years on their health partnerships team during COVID. How do you convince voters, I think was the question, to care about this? We work in vaccine demand generation, and I think what is missing is that we forget how quickly we forget. And there has to be ongoing messaging, unwavering political support, and from policies to interorganizational partnerships to interpersonal community organizations outside of the healthcare sector, all the way down to our households, ongoing conversation about vaccines and how they work and how science is something that you can trust. And then I would say that we can do that through a lot of different ways, using a lot of digital media. Let's talk about education and our education systems, and really get down to, I think, the individual education and societal awareness of the benefit, because simply we forget we now are at, I think, less than 50% of people getting COVID vaccines. And it was less than 5 years ago, we were all not allowed to sit like this.
I just wanted to, sorry, if I can just add, I've thought and answered your question now. I think it's not just about science and evidence. That's the starting point. It's about emotion. And it's about people's stories. And it's about actually showing people what the consequences are in terms of their own lives, their families' lives, their friends' lives, of not doing what we think is good for them in terms of their health. So I think it's about storytelling, really, and getting that first and foremost in people's minds, so they realize or understand the consequences of not investing in health, because more people get sick, more people die.
Okay, Peter, thank you very much for that. I'm going to take one more question. That's all we've got time for, but I can see more than one hand up. For those that we don't get to, could I please ask you we're having refreshments later, please come along and make your question known to whoever of the panelists that you would like to speak to. The gentleman at the back there with his hand raised.
Yes, hello, my name's Mark Cozell. I'm a pharmacist from the UK. My association represents 40,000 pharmacists. I've got a question for Sahel, actually, because I agreed with much of what you were saying, which is to embed early detection primary care. Now, you gave the hypothesis, primary care is one person sees one person. Actually, in the UK, which you referred to, you've got more people going into a community pharmacy every single day than the whole of primary care put together. And the really good junction in the road is where public health meets population health. And in the UK, we've been quite successful at getting all of those messages across to members of the public. Not because they come to see us because they're ill, they come to buy the baby milk or what have you. Do you think perhaps the WHO could take a close look at the benefits of community pharmacy to supporting that kind of increased, enhanced awareness of some of the issues about?
Okay, thanks, Mark. Sohail?
Can't agree more. What you said, I think is what we should need to embrace more systematically. I think the positioning public health at primary care level, when I say primary care, is GP surgery plus, including the community health worker, dental surgery, pharmacy, all should be encompassing. But the issue again, I think you know that because I am from Oxford and I know that many of the GP surgeries, unfortunately, has started to close down, or they are becoming part of a clustered center. So there is a reverse trend. I think the issue again is how we can convince, I think as David mentioned, that we need to convince our politician that this is an investment and this is not just an expense in the budget line. And we also need to convince that this is not a transactional investment. I think some of this investment, I think we cannot economically quantify. But if we want to consider health as I think we all say is a human rights, etc. But I don't know whether that is now good enough to convince our politician. That is the reason why I'm using the word a premium, like an insurance. So we need to come up with a different narratives to convince the politician that this is a premium to pay. If you look at the COVID experience, how all government business functions can collapse if health sector is collapsed. So can we come up with that premium? I don't know the right narrative, but, or maybe, I mean, if you think about Marcus Rashford, I mean, the guy, the footballer, the way he advocated for the meal voucher for children. I don't know whether we need to gang up with people like that or some of the celebrity that we need to develop an alliance. I don't know. We need to come up with a different narrative, different tool for advocacy as a help. We are not very good on that. So we need some allies there.
Finally, from the
Yeah,
panel, the
just-
last words.
Quick comment. I love this question because we've been working with folks in Rwanda, Uganda, and Kenya to do some implementation science to figure out how to use pharmacy networks to increase access to vaccines in the life course. Nothing solid yet, but it's something that we see as this very fragmented pharmacy network in some of these other countries, but might be more solidified in places like the United States with like Walgreens and CVS and maybe in the UK. There has to be a there, and I'd love to follow up and talk to you about this because we think we have to get creative. There's narrative changing policy advocacy, and I think there's actual structural changes where we task shift and new technology like microarray patches, which is instead of the needle and syringe, you just pop it on skin. Let's task shift and give our community health workers or nurses, well, nurses already do this, but you know what I mean, task shifting to give other people the opportunity to vaccinate. So we are doing microarray patches, and measles, rubella is the first, but like many of the others, and I'll leave you with a story. Imagine my mom was 64 years old and she had early onset Alzheimer's, and we are in phase 2 trials of these vaccines. Her local pharmacist was the person who helped her navigate and me navigate on the phone how she could keep getting the care and the medication she needed to sustain her until she needed much more than that. So these pharmacists are people who we come to trust, whether you're in a semi-urban village in Kenya where I used to live or in San Francisco, California. So I think there's a huge amount of innovation that we have to think about, simple ways that we use human connection and trusted relationships to increase longevity across our life course.
Thank you, Whitney. A wonderful way to close our formal proceedings. which it's now time to do, I'm afraid, although I'm sure the conversations are going to continue, not least at our networking reception downstairs, which is following. Just reflecting back on some of the things that I've heard this afternoon, I know that each of us will take our own different thoughts away, but there was the call for longevity literacy, I think, from Marco. Massively important point. How are we going to change society so that it's more equipped to deal with some of these issues coming up? And call from more than one speaker for a change of mindset, a paradigm shift in the way we think about things. I mean, my business coach back in the day used to tell me, Lawrence, the way you think about the problem is the problem. And we've got to get round, I think, that way of thinking to provide ourselves with more lenses to see these problems through different perspectives. And then, of course, a very simple call. We know how to do it. Just do it. You know, there's so much that we already know that we're just not doing. And shame on us, frankly, if we continue with that mindset. And then we heard from David. He's got the investment to beat all investments ever for the financial community and all the finance directors and ministers you can think of. A 19-to-1 return within a year on an investment. It's called global immunization. What's not to like? You know, let's begin some of these connecting the health and the finance ministries together, because I mean, when I was in the investment industry, you used to look at expenses as expenses. You didn't classify investments in the same way. And the more you could invest, the better it would be, because the return was going to come through sooner down the road. And maybe finally, just standing back from it all, did I hear a call to think about, what are we here for? What's society about? And if we can't do some of these things, then shame on us, you know. This is a motorway that we should be driving down at full speed. Now, I'd like to thank our fantastic panel, Whitney, David, Marco, Soel, and Peter, for sharing their wisdom, insights, as well as their provocations. And of course, a big thank you to Aaron for drawing out the new insights from the index data and for launching the ILC's most recent report on HIV. They've left us with much to build on and much to action. The ILC is proud to have developed the Healthy Aging and Prevention Index as a catalyst for accelerating our collective ambition to promote better health outcomes. It's the gift that keeps on giving. And I want to wholeheartedly thank our funders of this exciting program: Amgen, Boehringer Ingelheim, Gilead, GSK, MSD, Pfizer, and Sanofi. Without your support, ILC would not be able to fully play its part in championing an evidence-based approach to advocate the beneficial changes which society should make to adapt for longer lives. We look forward to continuing our collaboration with our partners across the world on our shared endeavours. But first of all, please join us for refreshments at our reception downstairs in the Fontana room. And I'd now like to invite you to congratulate our panel in the traditional way. Thank you.